Thinking Rare. Because every rare kidney disease in children deserves deeper thinking. Thinking Rare is a podcast by ESPN, the European Society for Pediatric Nephrology. This content is designed to inform and support clinical learning, not to replace professional medical advice. Please consult a healthcare professional for personal health decisions.
Hi, my name is Garrelfs. Welcome to this episode, Living Beyond the Diagnosis, the psychological experience of rare kidney diseases, where we explore the clinical thinking behind rare kidney diseases in children, together with the human experience that accompanies them. Each episode is designed to fit into the time of a coffee break, around 15 minutes to reflect on complex cases, share expert perspectives, and discuss how we approach challenging diagnosis in pediatric nephrology. Today, I'm joined by a colleague who brings valuable experience and insight to this complex topic. Here with us today is Dr. Kraft, a psychologist working at the University of Hamburg, a large transplantation center. Welcome, Stephanie.
Thank you for inviting me to this podcast. Thank you very much. Yes.
So before we dive into this topic, Stephanie, can you tell us a bit about your journey? How did you become a psychologist and what brought you to this field?
I was always interested very much in medical psychology, which as a discipline basically combines psychological principles and medicine in order to improve patient care. After my graduation from university, I first started to work with adult liver transplant patients. And later on, I focused on families and children and did my training as a clinical child psychologist.
Do you drink coffee?
Yes.
Okay. How do you drink your coffee?
Black with milk.
Black with milk. Because coffee is probably the largest fuel of hospitals. So I'm just curious. So how can psychologists generally contribute to patient-centered treatment in a pediatric medical setting, Stephanie?
Well, I guess chronic illness in childhood can fundamentally impair developmental processes, and this is with respect to, well, cognitive, emotional, and also social abilities. And if children are unable to cope with the challenges in their development, the risk of developing a mental health disorder increases. And therefore, I think psychologists should help to recognize and understand each child as an individual development and also within family and social structures.
In your opinion, Stephanie, what are the most important challenges that families face when they have a child with a rare kidney disorder?
Families of children with rare kidney disorder, they face multiple challenges, of course, and they are frequently burdened, for example, but not being able to work, and therefore meaning they suffer from financial constraints. They have to take care and look after the siblings, which are often at home, which need to be taken care of as well. If the parents accompany their children to a hospital, stay in hospital for several days, sometimes even weeks. And if they accompany their children to appointments, medical appointments, of course, they also have to be there for interventions, for medical interventions. They have to be with the child if the child suffers from painful interventions. They have to restrict often the diet, have to take care the children are not drinking too much. And if I talk to parents, a burden which they often express is being in a double role of being a parent and trying to save the child from pain, trying to look after the child and give the child a secure surrounding. And at the same time, they need to be in the role of being a health assistant and helping the child to go to the medical appointments, sometimes to have the needles with growth hormones every day at home, They have to be in hospital when the children are facing difficult, painful procedures. So they are very much in a double role of being a parent, trying to save, and at the same time, they need to exhibit the child to difficult medical procedures. Yeah.
So I'm a young parent myself, but I can imagine that it's really difficult to have such a double role. What can we do to protect the parents, but also the other children in these families?
Well, we know that parental stress is linked to poor adherence. So we, as psychologists, try to strengthen the family functioning. And family functioning, we also know, is a protective factor to reduce the risk of behavioral problems in children. And we do often see parents who exhibit like a very high levels of anxiety. They suffer from mood problems, and also, especially after transplantation, show symptoms of post-traumatic stress, and even symptoms of post-traumatic stress disorder. So we know there are a lot of symptoms parents exhibit, and I think it's very important to either talk to the parents themselves and try to reduce stress.
And the siblings, because what I see in the clinic a lot myself is we have siblings roaming around the dialysis ward because there's no other place if there's no grandparents, or if they don't go to school yet, or they don't have daycare. In your experience, is that a good thing to have siblings of these patients involved in the medical treatment? Should we involve them? Or is it actually in their development not a good thing to play such a big role in the therapy of their sibling?
I think it's difficult to answer the question in general. My experience, it very much depends on the family. If the family has a very broad family structure with grandparents living nearby, and with grandparents being an opportunity for the child to establish a structured day with kindergarten, childcare.
We've been talking about primary hyperoxaluria type 1, which is a rare kidney disorder. Once it's diagnosed, there are a lot of uncertainties. And that's common of course, for a lot of these rare kidney disorders with new therapies, but also heterogeneity in clinical prognosis. So some patients progress to kidney failures, and other have a more benign disease course. So what do you do, or what is your support when a doctor or physician is diagnosing a young child with such a difficult medical disorder with an uncertain prognosis and clinical expectations? So what do you do, or what is your role in the disciplinary approach at the time of setting such a diagnosis?
It depends a little bit. Sometimes we are also part of opening the diagnose, but more often we're afterwards there to talk to the parents, to see how they cope, to help them coping, to offer them the opportunity to talk about that. Sometimes we try to connect them to other parents who have made the same experience, who have the same children with the same diagnosis. So we try to do as well, establish a peer connection so they can talk to other families as well.
What is it that we as physicians can learn from you as a psychologist in better understanding what patients, and especially children from different age groups, of course, require, but also parents? Because I can imagine that we can learn a lot from you as a psychologist to really open up the conversation and better understand what they need in different phases of the therapy. Is there any advice that you can give?
In terms of the children, maybe I answer that first. This is very interesting because I have learned a lot myself from the children and from the adolescents. And I have one citation basically from a 17-year-old, which has impressed me a lot. And maybe I cite it, and because this is what I have learned, because she was like 17 years old with kidney failure and has spent 2 years on hemodialysis before she underwent kidney transplantation. And she once told me, and I cite her, and she said, if everybody would carefully listen and take us seriously in why we do certain things and why we don't do certain things and how we feel, we would feel more open in saying why we didn't take the medication, why we drank so much or ate wrong food. I think really listen to the children and also to the adolescents can really improve adherence and understanding.
And that's a really important topic, especially for adolescents and teenagers, of course, not taking their, for example, phosphate binders, not taking their citrates, or even immunosuppressants after kidney transplantation or even liver transplantation.
Yeah.
So I'm really interested in this girl that told you we should have listened to her to better understand why she wasn't taking her medication.
Well, with after the transplantation, I think it's very important as well to consider not only the medication, but as well the social and the family setting. And that's the reason why I think psychologists and also social worker are very important in the team. Because if the children and adolescents sometimes spend, as I already said earlier on, a long, long time, for example, in hemodialysis, they make friendships there and often have very close relationships to the other children, to the adolescents.
Even though like having or receiving a kidney transplant or liver transplant is a very positive thing treatment wise, but what you mean is that they actually lose their second home.
Yeah.
Of course, the safe environment of a dialysis ward, and also the treating nurses, physicians, psychologists, everyone, and of course also the other patients inside the ward, probably the most important thing,
Yeah.
are having like the same problems and that really understand what they are going through, that lose their second home, which is also a very negative aspect of actually undergoing a transplant.
So what's for the patient, apart from the physical improvement, what's the gain of the transplantation afterwards?
Yeah.
Is there more gain or is there more loss? And if there is a lot of loss, we have to replace and build up beforehand.
And then talking about adolescents that turn 18 or even become 21, not sure what age range you have in your center, that patients need to move to adult care.
Yeah.
That's also a very big step. And I'm curious, what do you do in your center to really educate or support them in such a big step they need to make, changing from pediatrics to adult care, which can also be a really large event for a lot of these patients.
Well, we're trying to, I think it's probably in most centers the case, we try to start the transition process very early. So we start with about 13, 14 already to talk to the patients, to the families about moving later on in a different center.
Thank you very much, Stephanie. It's really nice talking to you on a very important topic, I believe. We've discussed a lot of challenges that parents and also children have with a rare kidney disorder, transplant care. I really liked your last point that we should introduce or at least include patients and parents or caregivers in clinical decision making.
Well, thanks a lot for inviting me to the podcast and giving me the chance of contributing psychological aspects into the medical
fields, yes.
routines, yes.
Yeah, which is really important. Thank you for listening to Thinking Rare, a podcast by the European Society for Pediatric Nephrology.
This was Thinking Rare, the ESPN podcast on rare kidney diseases in children. This episode has the unconditional support of Alnylam. For more educational resources and upcoming episodes, follow us on the ESPN channels and visit www.espn-online.org.